Hi everyone, I'm Natassia, one of the gastroenterologists and hepatologists who works across the Alfred and Eastern Health, and I'm a current PhD candidate with Monash University as well, doing a PhD on primary sclerosing cholangitis. So really want to give thanks to Kerry for inviting me to speak and for organizing this event, which is of course very beneficial for everyone. So today I'm just going to speak a little bit about the liver and how it affects, how it's affected in PSC and an Australian perspective, just looking through some of the data that we've been working on. Just go next slide. So what's the liver? So the liver is the main organ that is affected in PSC. So of course, we're going to have to talk about that. So your liver is the largest internal organ in your body. And it gets a large portion of its blood supply from the portal vein, which is a vein that drains all the blood from your intestines. And it consists of liver cells and also vessels, which include arteries and veins, and also bile ducts, which I'll be chatting a bit more about in the next slide. Where is it? So it's in the right upper part of your abdomen, right under your diaphragm. And the gallbladder just sits underneath the liver, and obviously they work together as a unit. And why do we need our liver? Why is it so important? So it's very important in processing foods that we eat, also processing any medication or toxins, and is in charge of detoxification, if you like. Also in charge of production of important proteins like albumin, clotting factors in the blood, and it forms and secretes bile, which gets stored in the gallbladder and assists with digestion as well. And also importantly, is an important part of the immune system, so in charge of protecting the body. The biliary system, which is part of the liver and its functions. So I'll talk a bit about bile, which is what flows through the biliary system. And if you can see on the right, there are a couple of pictures which show the gallbladder, which connects to the bile ducts, and there are sort of small ducts and larger ducts as well. And these are the sort of parts that get affected in PSC. So bile is a digestive fluid that's produced by hepatocytes and bile duct cells, and it assists the liver in excreting substances. As I mentioned previously, it helps in digestion and absorption of fat, and it also assists in modulating the immune system and sugars and fat metabolism. So the biliary tree, which is the tree-like structures that I've just spoken about, its main function is to sort of modify, make it a bit safer to transport and store bile from the liver to the intestine. So bile is normally secreted into the bile ducts, flows down into the common hepatic duct and the common bile duct, which is the sort of blue large duct that you can see here on the bottom right. And this flows into the small bowel where it can sort of get started in its digestive processes. And when there is disruption of bile flow, so whether there's a stone or a narrowing of any of the bile ducts, we call that cholestasis, which you may hear as part of your consults with clinicians. So primary sclerosing cholangitis, which we will be referring to as PSC, which is much easier to say. So I'm sure as all of you know, whether you're a patient, carer, or clinician or allied health member looking after patients with PSC, it's quite an uncommon liver condition resulting in inflammation of the bile ducts. And because of the chronic inflammation, it results in scarring and multiple areas of bile duct narrowing, and which is what we sometimes term strictures. So PSC has a strong association with inflammatory bowel disease, which some of you might have. So this consists of Crohn's disease or ulcerative colitis, or in some patients, we're not sure what phenotype it is, and we call it IBD, undifferentiated. And it's also strongly associated with certain types of cancers. So in particular, liver cancers, bile duct cancers, which we term cholangiocarcinoma or CCA, and colon cancer as well, if you in patients who have concomitant inflammatory bowel disease. So who can get PSC? Essentially anyone. However, we know that it's more common in middle-aged men, and it's much more common in patients with inflammatory bowel disease as well. So What goes wrong in PSC? So this is a busy slide, but maybe let's focus on the picture in the middle. So essentially, we still don't know exactly what causes PSC, but our working hypothesis is that its pathogenesis or its cause is similar to that of inflammatory bowel disease. So there are probably underlying genetic factors that affect how the immune system works, and particularly, especially how the immune system works in the liver, the intestines, the bile ducts. And there may be environmental triggers of which we're not 100% sure what they are. And they may trigger sort of dysfunction and increase activity in the immune system. And there is often cross-communication between the gastrointestinal tract and the liver. If you remember me saying all the blood from the intestines essentially go through the liver to get to the rest of the body. So, there is cross-communication there and links, and we feel that there might be dysfunction in the immune system due to underlying genetic factors, modification or alteration of the bile acids that make them a bit more toxic to the bowel system, and interactions between the gut microbiome as well. Exactly how, we're not sure, but there's definitely a link between all of this. And that culminates in what I've mentioned before. So remember, I spoke about narrowing in the biliary tree or constriction. So that results in what we see on scans. And if you can see in the bottom, in the middle, sort of beading of the biliary tree. So we get them inside the liver and outside the liver. So that's essentially the process that happens, and what that can result in. If you look on the bottom left, patients can actually get infections because of narrowing of the bile ducts that leads to buildup of bile and bacterial infection that can happen. And patients might need a procedure for that to open up the bile ducts and relieve the infection along with antibiotics. And with long-term progression, some patients, not all, may develop liver scarring. If you look at the top right, that's a liver with cirrhosis. And cirrhosis is just a term where how we describe end-stage scarring of the liver, which results in a sort of nodular appearance. And I'll just go through a bit later on how we manage that in PSC. So how do you know you have it? So usually about half of patients actually don't have symptoms, and they're usually diagnosed after they're found to have abnormal liver function tests, whether it's screening tests with a GP or for work health checkup. If symptoms are present, these are the common ones. So abdominal pain, usually in that sort of right upper abdomen region where the liver and gallbladder is, itching, yellow skin, which is what we call jaundice as well, and fatigue. So how do we diagnose it? So let's say you have abnormal liver function tests and your GP refers you to see a specialist. So in our thoughts, we, of course, after ruling out other things, we usually proceed with magnetic resonance imaging. So it's a cross-sectional imaging of the, particularly of the liver and the biliary system. And we are looking for changes in the bile ducts, which we've seen in the previous images. So beading of the bile ducts, narrowing, etc. We also need evidence of cholestatic LFT liver function tests. So remember cholestasis, which is a result of buildup of bile because of these narrowings. And we see that with increases in bilirubin, ALP, and GGT, which is part of the panel of your liver function test. We only do liver biopsies in certain clinical situations where we have a strong suspicion a patient has PSC, but imaging doesn't show any narrowing. So we may do a biopsy because sometimes these changes are only happening in the smaller bile duct, so we can't see them on imaging. So can we fix it? As I said, unfortunately, liver transplant is currently the mainstay of treatment for patients with severe PSC. So patients who have very significant cholestasis, despite procedures where we try to open up the bile ducts, and also patients with cirrhosis, as I said. So this is the current mainstay of treatment for our PSC patients. As I mentioned, endoscopic procedures, you may have heard the acronym ERCP before from clinicians. This may be required to open up narrow bile ducts to improve symptoms and liver function tests. And as I said, in infection, which is ascending cholangitis. There's no proven effective medical therapy yet, but fortunately there are trials going on in the background. So hopefully in the future we'll be able to have an effective medical therapy for PSC patients. Ursodeoxycholic acid is a bile acid analog, which some of you might be on. And in moderate doses, it helps with improving liver function tests. But unfortunately, we don't have enough data to say that it actually prevents progression in PSC. However, at moderate doses, it's safe to use and may prove to improve your liver function. As I've mentioned, liver transplant, there's excellent post-transplant outcomes. PSC can recur after transplant, so we do keep a close eye on these patients. And we know that how the management of inflammatory bowel disease before transplant may affect outcomes. So for example, patients with colectomies before may have less recurrence after. And after transplants, about a third of patients get better, a third of patients get worse. Not sure why, but there might be an interlink there. So you remember there's a cross communication between the liver and intestine. So that's a brief introduction on your normal functions of the liver and bile duct and what happens in PSC. Hopefully that gives a bit of a basic framework before the other talks as well. So I just wanted to talk a bit more about PSC in Australia and a bit about my own research. So what do we know about PSC in Australia so far? So to date, there's only been 2 published local studies, one based out of New South Wales and one based out of Victoria. So in New South Wales, they looked at 208 patients from Sydney, where most are from a transplant centre. And they looked at outcomes and looked at comparison in patients with also inflammatory bowel disease and those without. And also in Victoria, from a single centre, we looked at 39 patients. And there were quite significant differences between both. And we do know that patients who are actually seen in a transplant centre are usually a bit sicker because it's, the sicker patients do get referred to transplant centres. So there's a bit of referral bias there. So we thought to do what we did. We did a multi-centre study looking at transplant patients and non-transplant patients to get a better understanding of the natural history and outcomes of PSC in Australia. And I'm going to talk a bit about some of the research I've done. And we've written a manuscript, and this has been accepted for publication in Hepatology International. So hopefully will be coming out later this year, and we can share that with you. So what we did a retrospective cohort study across 9 tertiary referral centres, including 2 transplant centres in Melbourne, Sydney, and Adelaide. And we looked at patients diagnosed between 1st of January 2000 to 31st of March 2021, just to get more reliable data, as patients diagnosed before then, we might have lacking medical records. So we included all patients with a diagnosis of PSC based on compatible liver tests, and cholangiogram, which is, remember the MRI findings that we spoke about before, and histology findings from liver biopsies. We ruled out patients with secondary causes for sclerosing cholangitis. So there are other things like drugs, certain infectious diseases that can cause these. So we excluded all these patients, and local data was reviewed to ensure that we removed the duplicates who were referred from non-transplant centers to transplant centers. So we had data on 413 patients, so the largest cohort, and it did include patients from the previously published studies as well. So looking at the cohort as a whole, so the median age of diagnosis was 37 years. Most patients were white, so about 88%. 65% were male gender, and about half were from a liver transplant unit. And we had quite a long follow-up time, so about 3,285 person years of follow-up. So quite a large cohort and good numbers. So it's a very busy slide, but I'll just describe that large duct PSC, which is where you can see any changes on MRI, whereas small duct PSC is where you can only see it on liver biopsy. So majority of patients had changes on MRI, so that's 90%. And some patients, about 15%, had an overlap syndrome, and that's what we call autoimmune hepatitis, where you get inflammation of the liver cells due to your own body's immune system attacking it. So it's less common in adults, but more common in our pediatric cohort. A dominant stricture is a significant narrowing, which causes symptoms and significant change in your liver function. And it requires endoscopic therapy to open it up most of the time. So about 27% of our cohort had that. End-stage scarring of the liver, cirrhosis, that was in about 40% of the cohort. And decompensation is where you have complications from the cirrhosis, that was in 20%. Quite a few had inflammatory bowel disease as well, as you remember me saying, 71% of the cohort, and 64%. So quite a few of you would probably be on ursodeoxycholic acid as well. So looking at the liver biochemistry at diagnosis, so most commonly there was a raised ALP, so that's the third line from the top. So that's one of the markers of cholestasis. Bilirubin was mostly normal when patients were diagnosed. Some patients had activity of inflammation as well. So if you look at the ALT and AST on the top, that was slightly above normal limits. So perhaps this might be affected by overlap syndrome, or when you do have significant cholestasis, this can result in mild inflammation as well. So looking at the epidemiology, so we calculated the incidence and prevalence in Greater Melbourne. So incidence, the number of new cases that occur per person year. So this is a rare disease, as we've mentioned. So there are only 0.27 cases per 100,000 person years. So this really varies throughout the world, with higher incidence in North American or European cohorts, but our average incidence is quite similar to that of those reported in other sort of similar cities like London. In terms of point prevalence, so that's the number of cases that are per patient or inhabitant. So in 2019 to 2020, there were 5.9 cases per 100,000 inhabitants, and that's similar to other European cohorts as well. And as mentioned, there are more males than females. And you can see this the graph on the right is looking at the incidence and sort of increased since 2000 to 2010, 2015, and whether or not this is related to improvements in MRI technology, more frequent liver screening, we're not sure. And perhaps a slight dip down going towards 2020. So now going through some of the results, so clinical outcomes. So first we'll just talk about cirrhosis. So about almost 10% of patients were already cirrhotic at diagnosis. And remember, I did say that 50% of patients are asymptomatic at diagnosis. So perhaps these patients may have had disease that was undetectable and then presented at a later stage. So 50% of the cirrhotic patients, which is 20% of the cohort, had decompensation. And how we describe that in cirrhosis is patients who collects fluid around the abdomen, so that's called ascites. They become confused, so that's called hepatic encephalopathy, or they may bleed from increased pressure in the veins in their food pipe, so we call that a variceal bleed. So those were the events that we used to collect these episodes in the study. And if you look at the graph on the right, so this is what we call a Kaplan-Meier curve, and looking at cirrhosis-free survival. So if you look at the lines so there's a graph that goes down, that trends downwards, and with every line that goes through the graph, that's for every patient that develops cirrhosis. So as you can see, as we go down to 50% of the cohort would be diagnosed with cirrhosis at about 16 years after. So it does take a bit of time for cirrhosis to develop, if obviously we catch it at an early stage. And as you can see here, just to reiterate, so this looking at the risk of development of cirrhosis, so the risk does increase gradually after PSC diagnosis. There is a small blip at year 0, and I feel that might be the patients who may have had undiagnosed disease that was undetected before. So now moving on to clinical outcomes with malignancy. So there's a couple of lines here. So the blue is the risk of bile duct cancer, which is cholangiocarcinoma. The dashed red line is the risk of colorectal cancer. And the dashed green line is that of hepatocellular carcinoma. So the risk of hepatocellular carcinoma, which is a type of liver cancer, stays stable throughout. And we've seen in our cohort, this only develops in patients with cirrhosis and PSC. The risk of cholangiocarcinoma and colorectal cancer does increase throughout, with the highest risk about 7 to 10 years after diagnosis. And we do know that in patients with cholangiocarcinoma, the outcomes are unfortunately poorer than those without. And this just shows that survival is less in those with cholangiocarcinoma, and not only death from cholangiocarcinoma, but all-cause mortality. In terms of looking at how many patients passed away during the follow-up period, or those who had a liver transplant, so about 1/3 of patients died or had a liver transplant, and the median transplant-free survival. So if you remember, every dash throughout the graph is that of either someone passing away or someone having a liver transplant. And once you hit 50% of the cohort, so that would be 13.4 years. So similar results to that of cohorts from North America and Europe, and probably largely because about 50% of our patients was from a transplant cohort, so quite a few had liver transplants. And something else that we did, we compared the relative survival of our PSC cohort to that of the Australian general population. And how we did that, we compared patients. So if you look at the bottom age groups, so that's comparing PSC patients at age of diagnosis. So in the less than 30, so patients with PSC who were diagnosed at less than 30 to 45, those who were diagnosed between 30 to 45, and etc. And we're compared to similar age groups in the general population without PSC. And just to summarize the graph, red equals comparable survival to that of the general population. And we do pretty well in patients who are diagnosed from 30 to 45 or under 30 to 45. However, when we do have patients who are diagnosed at an older age, so above 45, and more significantly in those above 60, we do see that the relative survival does decrease when you go up the boxes. So it changes color more quickly and at an earlier stage after diagnosis. So what that means is probably once in patients who are diagnosed earlier, they have comparable survival, but in patients who are diagnosed a bit later, they seem to have a decreased relative survival compared to the general population at an earlier stage. And then we looked at important predictors of outcome. So we know that cholangiocarcinoma causes decreased survival, and it's something that is important and we want to look out for in PSC patients. And there's a lot of numbers there, but I just want to highlight 3 things. So we found that having a dominant stricture, having a previous colectomy, and having an increased age at diagnosis were significantly associated with increased risk of cholangiocarcinoma. And this is similar to previous studies as well. And looking at transplant-free survival, so the chances of having a liver transplant or passing away. So having a cholangiocarcinoma and developing cirrhosis, so the words highlighted in blue, were predictive of reaching a endpoint of that at a sooner time. So these were the sort of factors that we've identified for poorer outcomes. Oops, sorry. So that's just a brief summary of some of the results that I thought would be interesting and to share and to sort of improve your own understanding of PSC. So this is the first large-scale study of PSC in Australia, and as I've mentioned a couple of times, it has similar demographics, clinical features, and outcomes to that of European and North American cohorts. And I think it's very relevant because we've identified at a local level that a couple of things that we can look out for in managing and predicting outcomes in patients. So increased age at diagnosis, development of cirrhosis and cholangiocarcinoma, we know are risk factors for poorer outcomes. So these are the things we look out for. So as I mentioned, one step closer to understanding PSC at a local level, adding to the limited literature, it'll be the third published study on PSC in Australia. And as part of my PhD, I am undertaking ongoing studies to determine best predictors of outcomes, to identify patients who need increased monitoring or early evaluation for transplant. As I've mentioned, cholangiocarcinoma is one of the predictors of poorer outcomes. even there's no good evidence for surveillance for cholangiocarcinoma, but expert bodies and guidelines, and also from what we've taken out of our study, we do recommend regular surveillance, or at least yearly MRIs to detect any changes that might indicate cholangiocarcinoma or any other cancers. So essentially, adding to the limited literature that surveillance may be useful, but we don't have enough data on that at the moment. So I'll just like to have a plug for my prospective study, which is also being held across multiple sites in Australia. So this is an observational study, and with the aims I've sort of spoke about before, but we are enrolling all patients with PSC, and all that entails is data collection at the time of your clinic reviews. And we're also doing optional biosample collection, but we strongly encourage patients to participate because this is something that's really lacking in PSC studies. So we're collecting blood, stool, and bile duct brushings if patients do have a procedure for analysis, and also yearly MREs and MRCPs, which we can sort of couple up and use as for surveillance, but also to check for liver scarring. And we are looking at those changes sort of over a couple of years to see if we can use that to predict outcomes. We also like to link with your Medicare and PBS claims just to determine what sort of medications are associated with outcomes, and also once-off health-related quality of life questionnaire. So all in all, it's not a very time-consuming study for patients, but it really greatly benefit our understanding of PSC. So I have my email down the bottom, or if you're interested, just ask any of your liver doctors at any of your hospitals, and they might be in contact with myself. I just want to acknowledge these are the hospitals that were involved in our study, and my supervisory team at the top. And thank you for your time. Hopefully that wasn't too technical and it made sense, and I can take some questions. Thank you.